Okay, I'll try to do my best to, after lunch, late in the afternoon, to be a good closer. I want to talk a little bit about behavioral health care and how it fits into the general system. So we've talked a lot today about kind of at a practice level, and I want to talk to you a little bit about the system level and talk to you about how the system is organized, because my experience is most people that practice in healthcare don't really understand how it works. And I'm going to talk about a variety of topics. So I'm going to tell you a little bit about how my career developed, because I think it was relatively unusual. I'm going to tell you a little bit about where I work. Then we'll talk about how did we get to this bifurcated system, which really was very interesting and really happened in the last 30, 40 years. I want to talk to you a little bit about the inner workings of the healthcare system, triple aim, MBI, goals, in terms of the Institute for Healthcare Improvement. I'm going to use the term MBI for medical behavioral integration. I think you all mostly talk about integrated care. In the place I hang out, we talk about MBI. So I apologize for that. And I'm going to talk to you about ROI. So I'm going to give you like a 5-minute lesson on the business process of what happens if you're a manager in healthcare and how most of the system runs on a concept that's really very important called ROI. And then we'll do Q&A. So that's a lot. So a little bit about my career, and I'm going to make it real brief, but there's an important link back to here, which is I graduated from the counseling psych program. I spent 10 years working in counseling centers at Colorado State and on the faculty there, and then came back here to UT for 7 years and worked at the counseling center and taught a few courses in the department and really had a great experience, and then moved into private practice full-time, then building clinics, then building an MBHO that was regional, and eventually we were acquired, and I went to work for a Medicaid company called Centene, which runs health plans and Medicaid all over the country, and then went to United about 8 years ago. So that's a relatively unusual career. I went from clinician, including being the chief psychologist at Shoal Creek when there was such a position as chief psychologist, because psychologists still practiced in hospitals, to managing something very different. And the tie back to the university, we were talking about it at lunch, was that I think I got the foundation to be able to do all of those things in 3 different ways. I got very good clinical training, which was really important. I got very good training in program development at the counseling center. And I got very good training in organizational development by a woman some of you might remember named June Galsich. So I took a year course in organizational development. I did a year practicum. And so I left here not thinking about just clinical work, but I left here thinking about organizations, program development, and how clinical work, program development, and organizational fit together. And that's really been the thread throughout my career. So I now work at UHG, which is a Fortune 20 healthcare company. You probably know it as United Healthcare. And United Healthcare is one of the companies in UHG, and the other is Optum. I work at Optum, which is the healthcare services company. And I'm the CEO of a company called Optum Specialty Networks, which has one component of it is the behavioral healthcare company, and I'll come back and describe it in a second. We cover 60 million individuals, but I'll tell you a little bit more about that. And then the other parts of it are complex medical. We manage the largest number of transplants in the world, kidney, bariatric, infertility, and we manage PT/OT, chiro, benefits for a large population also. The thread across these 3 businesses are they primarily run either off of networks that we build or off of centers of excellence that we credential. So as an example, if you were going to have a transplant, a heart transplant, and you lived in a certain part of the country, if there wasn't a center of excellence in your town, we would fly you, your family, have the surgery done at a place that is a center of excellence, put up your family, and then take you back because we think the outcomes are so significantly better. So on very complex medical conditions, we build centers of excellence. Our behavioral health care network includes 150,000 different providers and hospitals. And we cover, as I mentioned, care for 60 million people. We also have an employee assistance program that covers lives in 140 different countries in those countries' languages. And so we have people that we see on a daily basis from Brazil to Australia to Europe to any place you can think about in the globe, except we don't do business in Cuba and North Korea. It's not meant to be a joke, it's just a fact. We also have, as part of our EAP, a service where we do global crisis management. So when the nuclear reactor disaster happened in Japan, we sent a team. When there's the shooting of a senator in Arizona, we sent a team. Some of the school shootings. And we do that clearly just as a service. So there's no charge. We don't charge anyone for that. We do it as a community service globally. So it's a fairly complex business. Most of it's centered in the US. Some of it's centered around the globe. We have offices in England and in Australia and in Brazil and Canada. And we have several outposts. They're very small offices in the Pacific Rim. So that's what I do. I get to work with an extraordinary team of 15 executives. In the behavioral health company, there are 6,000 employees. We employ 1,000 licensed clinicians that are not physicians. We employ 75 psychiatrists. Of the 1,000 non-MD clinicians, 40 are psychologists. So very, very small number. And that is, I'll come back to that point because there was a time when the behavioral health system was really predominantly managed and run by psychologists. That isn't the case anymore. So that's a little bit about where I work and how I got there. I think it's important to if you don't have the history, and there are people like Dave and Charlie Boone and others, old friends that certainly do have this history, but I want to talk a little bit about how did this separation happen? How did we wind up in such a bifurcated system? And I'm going to run you through a little short how does the healthcare system work? And as you probably know, the healthcare system was employer-sponsored. Mental health costs in the late 70s and early 80s were growing past 10% of all medical costs. And that by itself isn't bad. What was bad is that the quality of it was really low. And employers decided that there was tremendous variation and very poor quality in the service. And probably the best example of that is an iconic example is people for adjustment disorder with mixed emotional features were sometimes seen for a couple of years, which is not real appropriate. So there was a fair amount of waste. I don't think it was intentional. I think it actually was how people were trained. So there was waste in the system, and there was significant abuse, and especially by psychiatric hospitals. So you probably remember if you were around in the 80s, many psychiatric hospitals got shut down. They were paying school counselors to refer people for psychiatric care. So there was a fair amount of waste and abuse in the system, and employers really decided that they needed a different way to manage mental health, and to them, it seemed totally out of control. So, Biodyne was the first MBHO, meaning Managed Behavioral Health Organization, and it was formed by Nick Cummings, who was former president of the APA. He's a very interesting guy, still teaches a lot, actually is very interested in integrated care, and has some really terrific ideas about integrated care, but actually formed the first managed behavioral health care company in California, and wrote an article about psychologists as a primary care practitioner, which is interesting, as that topic has come up today, and also offered to set anyone up in any state to run an MBHO, and actually no one took him up on it. So several regional MBHOs were formed, and then organizations like Value Options, UBH. UBH is the legacy company of Optum Behavioral Health, APS, Green Springs, Magellan. If you've been in the behavioral health business, those names are very familiar to you. Green Springs is no longer in existence, got rolled into Magellan, but Magellan, Value Options, and Optum Behavioral Health, formerly known as UBH, are the three companies that predominate the way behavioral health services, at least in the commercial markets, is currently delivered. And these companies became known as carve-outs, and they shaped the nature of the behavioral health delivery systems. So behavioral health benefits, in this case, to understand what a carve-out is, it really is a health plan taking a certain amount of dollars and giving it to an organization to manage all the behavioral health care, inpatient, outpatient, the full spectrum. And so it's really a separation, and that separation caused significant fragmentation. So if you were the medical director of a health plan before these carve-outs, you could sit and look at some data and really understand what was happening with a patient or a member. And now after this carve-out, all that data lives somewhere else. So you had a view of it on an aggregated basis, but not on an individual basis. So costs were managed, quality was improved, there was improved focus, and it's really important to understand that organizations like NAMI were very interested in having a very specific focus on behavioral health. So you see this kind of disparate group of people supporting carve-outs, like large employers and NAMI, because they thought when it's embedded in a health plan, there isn't a sufficient focus on behavioral health. And it just gets lost in the flow of the healthcare system. So the MBHOs completed the bifurcation of behavioral health from the rest of the healthcare system. And it's, you know, I think the fair thing to say, it had some very good things that came out of it, and then it caused some very significant problems. And the significant problems, you know, many people have described. The integration, like a Cherokee, are really some of the solutions. But I'm going to talk more about the system level of what the solutions are and how they come to happen. So there's frequent confusion about how the U.S. healthcare system works. And I'm always interested, because I live in that world now, and I'm always interested in talking with people and really having a sense of not only how complicated our system is, but how poor the understanding is about how it actually works. So here's a brief and very incomplete, you know, Cliff Notes version of how the healthcare system works. So it's not totally accurate, but if you get this, you'll know more about it than most people. So there are sponsors, and they have, in the current system, expectations. There's a fair amount of instability, and I'm going to define who these sponsors are in just a second. And they create policy and determine funding. Most people don't understand that sponsors, in general, are the people that determine funding. Then there are healthcare organizations that, because of the changes in the current system, actually are experiencing a high degree of uncertainty. They're uncomfortable, and they organize, their duty is to organize the system and distribute funding. That is what health plans do. They build networks, they manage those networks for cost and quality, and they distribute funding. And then there's the delivery system. They want to deliver outcomes, both clinical and financial, and there are new expectations on the delivery system, where the delivery system is going to change in very significant ways, and the quality expectations and the ability to measure those quality expectations are going to vastly increase. So, who are the sponsors? Sponsors predominantly are employers, commercial health plans. So you belong, your benefits, if you're here at UT, are part of a large employer's benefits that they bought from a commercial health plan. It happens to be United. CMS, who regulates Medicare, and you remember the comment we were talking about earlier about code books? CMS publishes the code books. And we'll get to what the implication of that is over time. CMS and states, which sponsor Medicaid. So when we talk about Medicaid health plans, it's important to understand that they're partnerships between CMS and the state Medicaid offices. There are 50 different kinds of Medicaid health plans in this country, which correlates perfectly with 50 different states. And I want to tell you, we do business in 30 of them, and they're all very, very different. They all have different requirements. They have a different strategy. They're moving in a different direction. We live in a state that has probably one of the more conservative and restricted Medicaid offices and plans in the country. And then there's some that are very, you take a look at Arizona as a place where there's really a lot of progressive work done in Medicaid. And you have the kind of the examples of the opposite sides of the pole. And then the last, which people don't think about, I'm sure you do, is military. The VA, TRICARE, and all the active military forces. So these are the individuals that sponsor the rest of what we talk about in the U.S. as healthcare. So, who are healthcare organizations? You're probably most familiar with these: HMOs, PPOs, ACOs. Has anyone seen a really fully functioning ACO yet? Probably not. They're coming, though. MA plans, meaning Medicare Advantage plans, public exchanges, and private exchanges. Anyone know the difference between public and private exchanges? Okay. So exchanges are going to become very important. Public exchanges is the .gov website, or state exchanges, predominantly for people that are going to qualify for Medicaid. Private exchanges are exchanges that large employers are putting together to manage care and provide benefits in a different way. And we'll talk about that in a second. But private exchanges, IBM put a private exchange together and moved all their retirees to the private exchange. And in that exchange, if you don't know how, you know how it works because you live in Massachusetts, the originator of exchanges. But the way exchanges work is there are a certain set of defined benefits, and there's usually different levels, so silver, gold, platinum. And multiple health plans make offerings into this exchange. And then you as an individual go into that exchange and buy what you want. So that's now think about if you work here at UT, that at some point what might and what will probably happen is you'll be given a check and sent to an exchange. And that in that exchange you'll purchase what you want, you'll have more risk, you'll have a higher copay or co-insurance amount, and you'll design a plan for yourself that you think is the right plan for you. You might buy up some services like EAP, you might decide you don't want to do that, you might buy wellness, you might decide you don't want to do it, but there's going to be a core set of benefits that are part of each of the plans that will give some level of quality throughout the entire exchange. 2 years from now, and the reason this is important, IBM, GE, few of the companies on the West Coast have been trendsetters in terms of how employers manage benefits. 2 years from now, IBM is moving all of their employees to an exchange. So that notion of you sign up at the beginning of the year and it's taken care of is over in 2 years if you're an IBM employee. And what you'll be doing is going to an exchange and buying your custom-made health plan within certain variation. But the other thing that's going to happen is that you're going to pay a larger part of that health plan cost. So, healthcare organizations. We were talking about sponsors, we talked about healthcare organizations, and certainly public exchanges and private exchanges technically are not healthcare organizations, but they're a new marketplace. And then what we've talked a lot about today, which are delivery systems, individual practitioners, specialty clinics, vertically integrated delivery systems. I won't read the whole list. All right, that is the delivery system. And now we have a new entrant, right? If we talked about public and private exchanges, then consumers become really, really critical in this system, because for the first time, consumers are going to be able to choose their own health plan. Unless you were buying individual insurance, which is a very small part of the market, you're going to be buying your own insurance in an exchange. And employers are engaging in private exchanges, state and federal government. Consumers will choose their benefits. Consumers will be responsible for more of the costs. And it's a movement, and here's the analogy, from having a credit card with no limit and a limited responsibility for payment to having a card that has limits and requires significant payment. So what is happening, I mean, just is that there's been a frustration about what we've talked about, engagement and adherence in the system from everyone, from CMS to large employers. And what's now going to happen is you will be accountable. So if you decide that, you know, I just made a different decision, to Sandy's point, instead of following the recommendations, and if there's a cost associated with it, you will pay for it. And that's really different. And it's going to cause significant change, and consumers are going to, I don't think consumers understand yet what's happening, but I think that's going to cause a very different kind of marketplace, and it's going to hopefully stimulate people to actually take better care of themselves, but it will also stimulate a certain level of frustration about how this system now works. Because it really has been, for the most part, you had no responsibility for the expenses that you created. You got a credit card that you didn't have to pay the bill on. And now you're going to get a credit card where you're going to get a statement. So we have is really not much on this, but just a new entrance. And consumers, health plans and healthcare organizations are very concerned about the consumer movement, because think about what they were doing. They were selling health plan benefits to IBM. So IBM has 40, 50,000 employees at one time. Now individual consumers are going to make a decision, and that changes the marketplace to the similar marketplace of how do you buy your computer, or what do you buy on Amazon. You know, you can think of Amazon as a large exchange where you can compare a whole lot of different things and make a decision. So consumer impact on the healthcare system is going to grow over time and is going to become very significant. And I think overall that's a good thing. I think we'll pay a price as consumers for having that kind of impact. So the consumer is the last part. So probably important to understand that the current healthcare system, if you had to have an organizing principle about where we're going or what we're doing, or how does CMS and large employers think about the healthcare system, triple AIM's goals are probably a pretty good benchmark, which means the goals are improving the patient experience of care, including quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. When you look at those things, those are extremely complex problems, and they're not easily resolved. The first one is really the quality of the care that you're getting from your physician or your series of physicians that you see. The second is actually improving the health care of a population. That's very different. And the last one is, as you do that, the expectation that costs will go down instead of costs going up. And part of what the confusion is who has responsibility for each one of these things? Which part of the system, who's going to take care of it, and how will it happen? So here's the quick math course and the quick business course. If you talk to people, senior leaders at CMS or IBM or Medicaid offices, one of the common things that they talk about is ROI. And this is where we get to about integrated care, because the question is going to be asked, what is the ROI on integrated care? So ROI is a performance measure used to evaluate the efficiency of an investment. So here's the equation if you want to calculate it. It's the gain from investment minus the cost of the investment over the cost of investment, for all of you that didn't take the business course on ROI. But it's a really important concept. In simple version, for every dollar I spend, how much will I save? And the expectations often are, if I spend $1, I want to save $2, $3, $4. So when programs, our view has been a lot of integrated care programs get implemented. They often have a poor return on investment and then get taken down. So you heard the discussion about Cherokee. It lost a lot of money for a while. And organizations and delivery systems are not very good at calculating ROI. And what happens is that it has the potential to bankrupt your system. So there are at least a dozen integrated care projects that we've seen over the last 2-3 years go up and come back down. And that happens because to get to this, you have to really understand your expenses, you have to understand the value you're creating, and you have to understand the savings that you're creating by doing that project. In the long run, no one in the healthcare system, whether it's sponsors or healthcare organizations or you, will want to fund things that cost more money than they're worth. Meaning you spent, $1 and you got like no savings. In fact, you realize you're spending $2. And so the mismatch is the calculation, even at CMS level, is about this. I think the calculation on the delivery system is what's good for patients from a clinical and quality standpoint. They're not in opposition to each other, but the connection is what is good for patients from a quality delivery system and what increases quality and outcomes from them also has to save money. Now, the beauty of healthcare is that typically when you ratchet up the quality, the costs go down. But if your system is designed to spend a lot of money and get very little in return, you won't have the funding to be able to do it. So for all of you that are in graduate school, simple course on healthcare economics. Okay, so what's the status of medical behavioral integration? I think the short version is everyone's for it. I think sponsors, if you look at SAMHSA or you talk to people at CMS, there's strong support to do it. And it has, the reason I did the ROI slide first is because there's strong support but no funding, right? It's spend $1 of your own money with the hope if you're really smart, you'll save $2, $3, so you should be doing it. So there's very little funding except for pilots available. And as Perinda talked about, there are a lot of obstacles because coding, which is very important, which is how you get paid when you turn in something, doesn't really do a good job of taking into account integrated care. So there are lots of obstacles. Some of those obstacles, frankly, are Medicaid offices that don't support integrated care. Again, they would like you to do it, but they're not going to take encounters. Encounters are the way they report back to CMS about the money they spent to support it. So if there's no financial support, these programs are very, very difficult to do. So health plan organizations think it's the right thing to do. Sponsors do. People in the delivery system think so. They're wondering, just like Cherokee is, how will I get paid for it? And I think it's a really important question. What's the goal? Is it sustainable? And then consumers for the most part don't really engage in this discussion. They just want simplicity. They want to go someplace and get their health care needs taken care of. They don't want to go to 5 different places. They would like to go to one place. So consumers are really going to reward organizations that are aligned with that goal of simplicity. Okay, the IHI goals for MBI: coordinate care, co-locate care, build primary care capacity in-house. You've heard a lot about these different models. I think there are additional goals that are important to improve engagement. I think as psychologists, we have the skills to start thinking about what are programs that improve engagement and what are programs that improve adherence. And if you look at the healthcare spend and what it's contingent on and how you would really save money, whoever unravels the knot of improving adherence and improving engagement is going to make great headway. And I think we spend a lot of time talking about programs, but these two things are critical. We know how to treat people that have chronic illnesses. We don't know how to get them to comply. We know that we want to engage and have people be very active in their health care because it has huge payoffs. A simple thing like, will you walk every day? But we don't know how to engage them in really getting going and doing that. So you see a lot of different attempts. There hasn't been anyone successful that has really done, I think, a great job of improving engagement significantly or improving adherence significantly, at least not on a population basis. So, how do we move forward? Triple aim: improving the patient experience of care, including quality and satisfaction. I think these are going to be partnerships between healthcare organizations and delivery systems. So when we think about a patient experience at the MBHO level, at the behavioral healthcare company, we do a tremendous amount of care management. And we are integrating at a care management level. So we have pods that we've set up, if you can imagine 4 cubes that all face in instead of out, and 3 of those individuals are medical, and 1 of them is behavioral. And it starts out with those individuals managing people that have chronic illness that we do outbound calling to because we know they're not adherent. And eventually, it starts out with the medical people saying, oh, and by the way, do you have some anxiety or depression? They say it in a more sophisticated way. And if they do, they hand it off and say, sitting next to me is my partner, Matt, who would like to talk to you also. If you look 6 months later, you realize that the care management on medical and behavioral is happening with all of the people. They train each other. We train them, but they also train each other, and they get much more comfortable. And the nurses that are doing the medical get much better at doing care management for the behavioral, and the behavioral folks, to a point, get much better at doing care management of medical. At least they ask about issues. They ask about medication. They ask about compliance to getting checkups. And you start building at that level. So what we're trying to do at the healthcare level, and I'll talk about this again a little bit more, is take high acuity chronic patients and really care manage them in a very active way. We can't manage 60 million people that we're responsible for, but we can manage the top 10% of those individuals that we know have complex medical issues and have behavioral issues. And we try to manage them in an active way, and we're not doing therapy with them. We're actually trying to support them getting the right kind of care and trying to remove obstacles, whether that's a bus ticket, whether that's getting to a good provider, whether that's getting an appointment when they're struggling to get an appointment. So we're trying to manage in that way and push the actual care down into the delivery system where it belongs. Improving health of populations, I actually think in the broadest sense it's a healthcare organization accountability. I don't think in an individual practice, unless you define population as your community, but if you define population as a region in a state or a state, then I think it's healthcare organizations that have to organize the delivery system and organize care management to improve the overall quality. And reducing the per capita cost of healthcare, healthcare organizations, delivery systems, and again, consumers. Consumers are going to be individuals who I think are going to get burdened with a significant part of reducing healthcare costs. How do we move forward on the MBI goals? And again, what I've tried to lay out here is what are the goals and what is the accountability. And you can see most of this really is either the delivery system or a partnership between healthcare organizations and the delivery system. And part of my message is sitting on the healthcare organization side is it is hard, and again, I practiced for 20 years, it is hard to collaborate with practitioners. It is very difficult to engage them in thinking about systems of care, because often the kind of comment is like, you're here to do something to me, and we're actually out there most of the time trying to organize the system in a way that's functional. And sometimes we're out there saying, you know, you can't upcode this or you can't do that. But most often we're really trying to get people engaged of how do you move out of thinking about your income as how many patients you saw, and how do we move you to pay for performance? And all of our initiatives now are our pay for performance, meaning we're trying to move as much of the system as we can to paying for quality outcomes versus paying for units. So I've already covered the first point. There will have to be strong collaboration between health plans and organization delivery systems for MBI to be successful. I think there will be pockets like Cherokee. I think the work that you're doing, Sandy, and other people are, but I think for it to really catch on nationally, I think there's going to have to be collaboration and partnership between healthcare organizations and delivery systems. The data integration and analysis is really important. We spend a lot of time doing what we call identification and stratification. We spend an enormous amount of money trying to figure out who are the top 10, 15% of people in our population that have serious illnesses, both mental health or physical, who are not fulfilling their prescriptions, who haven't had a checkup, and we really try to engage with those individuals in an active way and get them back into the delivery system. And I think our engagement is often misunderstood. We're not trying to provide treatment. We're trying to get them back into the system to get engaged so that they can take care of their health care issues. MBI as a population strategy does not, I think, produce significant ROI. And by that I mean, I was really glad to hear, Sandy, what you said. I think it was 22 or 28% of the individuals got that integrated care in your clinic. We've been out in clinics that are trying to do that work, and they believe they're going to see 100% of the population, and you just can't do it. It is not cost efficient. It's actually not efficient from a quality of care. It is important for a segment of the population. I think the misunderstanding often is that it's good for everyone. So if MBI is a great idea or integrated care is a great idea, then everyone that comes in is going to get a mental health assessment, a physical, and the system can accommodate that, both from a practitioner level and from a cost level or from a quality level. So it's, I believe, a segment strategy. I think the place to start is with individuals that have high acuity conditions or chronic conditions and underserved members. And I think the last thing is I want to come back to what I learned as a graduate student. You know, organizational change is a pretty big deal. You can't change how delivery systems function, how healthcare organizations function without building the skills for organizational change and the management of that change. I miss where I sit more of psychology being involved in the healthcare system. There used to be a tremendous amount of psychologists involved, and there were people of my generations that are now aging out of the system. And so the system from a behavioral health system is getting managed more and more by MBAs versus Ph.D s. I'm the last Ph.D. managing a large organization in behavioral health, and I think that's a real shame. And I think there is an appetite in lots of different places to have psychologists engaged. I really appreciate the comments that were made today that people are going to have to change their behavior. It's not a 50-minute session, 6 sessions a day. It is really a different way of practicing, and it's a consideration of, is it important enough for you to be involved in the management of systems, and are you willing to take on the challenge of what we have to offer as psychologists to help change systems of care? Because I actually think we understand change in a very different way than your typical finance or MBA. So please come back into the system if you're students, and let us build a system where psychology, again, has the kind of influence that it used to have. So thank you, and I'll open it up for questions.
I'm not sure this is strictly an IBH question, but I've got a lot of concern about patient satisfaction. There was a recent study that doesn't always increase health outcomes, especially if it's patients having unrealistic expectations of the healthcare system. So, trying to judge everything by patient satisfaction, if they want antibiotics for a cold, for example, or pain medication for something that's chronic that you may not feel is appropriate. And I guess the other thing is, just from that broader perspective where you sit, is just also this ease of access to ERs and Mediclinics and lots of testing that will go on in ERs just because they don't know. My patients with chronic abdominal pain that end up in the ER and get a CT, whereas I know they have chronic abdominal pain and there's other issues we're working on. And I'm actually seeing more of that instead of less, and so I'm just wondering your perspective on all of that.
So a couple of comments. I don't think patient satisfaction is the ultimate goal. I mean, I think high quality care paired with patient satisfaction is the goal. And I agree with you that a lot of times, and if you're a behavioral health practitioner, you're always on that edge of, providing good care and knowing that sometimes that doesn't mean patient satisfaction in that session, right? It might mean something that's actually disruptive. So I don't think patient satisfaction should be the ultimate outcome. And to your ER comment, in this state today, since we decided not to participate and expand Medicaid, the reason we have lots of people going, and then this might not be your patient, to the ER, is because that's where they're getting their health care. And it's tragic for a whole bunch of different reasons, because they can't afford it, they get billed for it. It's also tragic that if you, have an abscessed tooth, you might get something for pain relief, but you're not going to get it solved in an ER. So ER, that issue, I'm going to take you back to the connection. As consumers wind up being more accountable for their own health care, they're going to get punished financially for using the ER. And there hasn't been a way to stop a certain segment of the population that actually has insurance from going to the ER. Now, some of that is because of the kind of mental health issues they have, but some of it is pure convenience. I don't feel good. I don't want to wait till tomorrow. I'm going to go to work tomorrow, so I'm going to stop in at the ER and get my care. I think what you'll see happen is that credit card analogy. You're going to get a whopping bill for doing that instead of waiting and going the next morning to see your primary care physician. Yeah.
Andy, so as you were talking about the private exchanges and some of the employers moving toward, if I understood you correctly, they would give a stipend to the employee and then send them into the exchange. It's always seemed a little goofy, but it's been the history of our country that health care is essentially provided if you're employed and by your employer, rather than in some other way that maybe is more equitable, but that's for another discussion. In 5 years or 10 years, do you imagine that it will be the case that employers are largely irrelevant to this process? Because if IBM is setting up an exchange for its employers, and they're just giving their employees money, why not raise their salary and say, we're out of this healthcare thing. You're kind of on your own. Here's some extra money for you every year. And then soon, will there not just be an exchange or a couple of exchanges that we all just participate in?
So one outcome, that's a great question. Thank you. I think one outcome could be that it evolves to that. But I think you have to understand what the dynamics are of a large company like IBM. So if they're going to hire someone to do their health care, and they usually hire multiple carriers, they're first going to go to Mercer and write a check for $1 million to do the RFP and score it. Right? Then they'll negotiate, and so they have a whole department that interacts on an annual basis to do that. And sometimes they have contracts for 2-3 years, sometimes shorter. And so what happens is they have a tremendous amount of infrastructure and cost that they're wanting to get out of there. I don't think they totally want to reduce the influence they have about the quality of the services that people get. So I think the private exchange will allow them to exert some influence in terms of what's available and what's kind of a base thing that you can buy, without some of the complications that they're having now by, I mean, just think about the expense. If you have 60,000 employees and you have to sign all of them up, even if you do it using technology, and you have to proof it, and then you have to load it, and you have to do all of that stuff, it's incredibly complicated and expensive. So I think what they're trying to do is get out of that. They're still concerned about productivity. You know, you saw the slide that Sandy put up, the iceberg. And so the productivity is still a concern, but I think they're going to shape it versus directly influence it. And what I think you're going to start seeing is that you'll get employers that have a like mind. Like, I wouldn't be surprised that GE and IBM put up an exchange together that have similar kind of ideas about what they want to do, and have a very small group of people managing the exchange, and then let, you know, the health plans that are involved in it manage the rest of it. So I think, but you know, that moves part of it, but I think what's underneath there is really a desire to cap how much of the healthcare premium they're going to pay. And there's a desire to not take up the slack. So if you talk to the purchasers in these large companies, they're always incensed about people that they believe it's obvious they're not taking care of their health care. And they're like, I'm just paying for them, and they're doing, you know, fill in the blank X, Y, or Z, and they're not filling their prescriptions for hypertension, they're not monitoring their weight, they're smoking. I walk out, and they're like, I'm tired of that. I'm tired of having accountability for that and no accountability with the individual. So one is structural, the other is a shift of responsibility. And I think what's missing in the discussion that's not very transparent is the shift in responsibility. And that shift over time will get greater. It's been getting greater. You know, we used to have $200 co-insurance. We have now $1,000 or $1,500. And that shift is going to continue to ratchet up until you feel enough pain to, at least in their belief, to do what you're supposed to do to take care of yourself. That overlooks all sorts of things, right, that you have no control over regardless of what you did. Yeah, David, back there and then up here.
Great presentation, enjoyed every minute of it.
Thanks.
When you discuss integration, maybe one way to talk between the health plans and the providers is a vertical integration. Here in Travis County, and looking at this integrated delivery system with Seton and Central Health and Integral Care, it's a lot of horizontal work, you know, between clinics and partners locally, and I think a lot of gains are being made.
Yep.
If there's 10 health plans in the area, and just we'll take Optum as an example with the 10% highest need folks, could have a situation where Optum is impacting 10%, just to give this as an example, of a population that's being integrated across a number of partners horizontally, locally. And you just think through, or just help me understand a little bit what that might mean for planning as an example, if 1 out of every 10 of our individuals that we're serving
Sure.
at the center are in a contractual relationship with Optum.
Yeah, so I mean, again, thank you. That's actually a great question. So we're not actually trying to anymore integrate vertically. You know, we're probably as integrated as we're ever going to get in terms of network. We're actually working very hard to integrate horizontally with our health plan partners. So whether that's Harvard Pilgrim or whether that's a UHC health plan, and the integration, and this is, I think, really important to understand, at that level happens around data first, right? So over in my UHC health plan in Ohio sits a tremendous amount of data that they have that's medical, and I have all the behavioral. What's happening now is in all of those places, we're integrating the data and then using a tool to do what I talked about, that ID and strat, which is to get to your 10% here in Travis County. What it typically means, which I think is not a very good system, is then we contact those people, we try to engage with them, sometimes out in the community, sometimes by phone, and try to drive them into the system that they're participating in. Right now, what would be better is if we had a kind of partnership where you saw the same data I did, that we actually pulled the data of the 10% that you're managing that are Optum folks, and we together really try to pull those people back into care, right? That would be a much better solution. We're at the point now where we can integrate the data, and we can find ways with our healthcare partners to push it out. I think what we're not very good at is building those partnerships, and I think what the delivery system is not very good at is wanting to do those partnerships. You know, we've been in opposition with each other in some ways for so long. It's a time, you know, to collaborate and partner, and I think sometimes it's difficult to find that common ground. I hope the common ground is data, right? Data about people that we really are worried about and that we think need really different kind of care than they're getting, which often means they're not getting any care, and it's not the delivery system's fault. And hopefully on your side, it means if I'm involved in pay for performance, you helping me perform well with this acute population really helps me, meaning you.
Thanks. I really appreciate you helping provide broader context around some of these issues. And I was wondering, when you commented about the ROI being maybe more favorable around certain types of levels of acuity and chronic conditions, does the data that you see suggest more focus within that, such as folks with more certain comorbidities or compliance histories or things like that?
Yeah, I mean, I think you take any of the cardiac conditions and diabetes and take any mental health condition across the spectrum. And I think our experience is there's significant improvement in that population. I think when you take someone with diabetes or CHF and they have very serious mental health conditions, the problem gets more difficult, but still I think there are huge payoffs. So it doesn't go down the full spectrum, but it's certainly, our experience has been, is that we just take chronic conditions and try to manage them in the way that I talked with Dave, but we have data, and certainly diabetes, any of the cardiac conditions, any of the pulmonary conditions, really there's significant ROI in those, and then the ROI drops down with some other conditions. And again, you know, you shouldn't mistake ROI as anything except a business planning tool, right? So if you're going to put a program together and you have passion about a program, then you really ultimately, besides thinking about the clinical components of it, should think about, I'm going to invest some money in this, how will it work out? You know, just like any other thing that you would do in a clinic setting. And, but I think it's a very easy way to calculate, you know, what the benefit is. Thanks for your question, I appreciate it. Any other questions? Yeah, Chris?
Me again.
Yeah, hi, Chris.
So when you were talking about the credit card analogy,
Yeah.
my brain started doing somersaults because I was trying to figure out where the delta goes in terms of the money. So you have more accountability going out to the consumer, right, down the road.
Right.
Which then influences their decisions to be a little bit more thrifty, right, and thoughtful about the kinds of, whether it's tests or going to the ER or whatnot.
Right.
Why then, and the reason that's creating accountability for them is that it's more expensive.
Right.
Right? So they're paying a larger share.
Right.
Who's getting that money? Like, so
well, it depends who ultimately the sponsor is getting the money.
So the consumer pays more, and so now the sponsor's making more money?
No, so think about it. It's a great question, so thank you for asking that. So this is kind of like you just
someone's
have to,
losing, and it's,
the
consumer's losing, so I want to know who's winning, right?
No, I get it.
Yeah.
So who's winning? So most people misunderstand. So organizations like United Healthcare or Aetna or any, they are managing money that comes from sponsors. They're typically keeping 5–6% hopefully for profit, for running all of that. But what will happen, so if consumers pay more, costs go down, Medicare rates will go down, so your taxes will go lower. Medicaid rates might go lower, meaning the combination of what CMS and the state pays a health plan for Medicaid, and employers will save money and pay less. But this is the common misunderstanding. It doesn't go back to the healthcare organizations or health plans. It goes back to the sponsors. And the sponsors, large employers, CMS and Medicare. CMS is just biting all the time on the benefits and the cost of Medicare because, you know, if you saw the statistic, 10,000 people show up every day. It's unsustainable. So they're trying to figure out, how do I reduce costs? So the way that money flows, they'll reduce the premium that MA plans, Medicare Advantage plans get, or they'll reduce on the fee-for-service side what they'll pay physicians if they get savings. They'll keep that money. Now, they might, if they were really brilliant, you know, which they usually are not, they will take that money and incentivize some other programs. But usually, they have two ways they can create savings. They can reduce what they pay out, or they can make you pay more so that, in fact, they can reduce. Does that answer the question?
It does.
And you know, this is like, I feel like all of us are involved in the healthcare system, but we don't get sometimes how it works. And if you're going to be involved in it, it's really pretty important that you understand where the levers are, who pays for what, how it works, where the money flows. And I know when I was practicing, I only really cared about the money flow in one way. You know, did my claim get paid? But at a system level, and what's happening is we're having system change, it's much more complicated. And the reason I try to put that stair step there is because that is sponsors fund, healthcare organizations manage and organize, providers, professionals provide the service that gets paid by the health plans.
Thanks.
Sure, yes.
I have a supportive rant and then a question.
Could we do the supportive rant first?
Here comes the supportive rant. That just came from a conference where the slides were about the relationship of healthcare costs to every other thing we do. And so when we talk about the money going back to the sponsors, it feels like some guys are over there getting rich. But what's really happened is that healthcare has cannibalized our whole economy.
Oh, absolutely.
Education is so much poorer today than it was 30 years ago. Everything that we want to do together is poorer because we haven't been able to keep healthcare from eating it all up. And
absolutely
so it's
right.
about moving the money back where we would rather have it be rather than just somebody's shareholders getting it.
Yeah, and it doesn't matter where you think about it, because if you think about CMS or Medicaid, it's your tax dollar, right? If you think about large employers, they're either moving money offshore to avoid a tax, or they can't compete effectively. And the reason they can't compete effectively is really was like your GM example, right? If $100 of that car goes to healthcare insurance and overseas $20 goes, you're not going to be able to effectively compete. And that's right. The way the healthcare system is managed is robbing a certain amount of vitality out of the economy. And if it continues to go, it will really make us a poorer nation. Yeah.
So my question is, as you think about people paying more and therefore being more parsimonious about use, I'm thinking of the guy who's living under the bridge, right? And he's very parsimonious too. He never comes in, he never gets care, his foot is swelling up, he's got something on his back that looks horrible. And when he finally shows up in the healthcare system, he's an economic nightmare as well as a clinical nightmare.
Right.
And so we want to get to him earlier.
Right.
And yet we're going to all be a little bit less quick to go running to our doctor as this evolves. How does the system get us in earlier? How do we maintain
you know, it's
prevention?
a great question. So I sit in a lot of rooms where people are designing programs. And I want to answer your question in two parts. And what often comes up and what I say is, look, not everyone in the healthcare system makes 6 figures, has 2 degrees, and is Anglo, right? And you keep designing this system as if that were true. You're not designing this system for people that are really poor and economically disadvantaged. And I think that's a common fallacy in the whole issue about consumer. Because the people that design those programs think, now I know I'm going to have to spend more money, so I will do the right thing. And for a certain segment of the population, maybe that's true. We don't know yet. I guarantee you, for the guy living under the bridge, it's absolutely not true. And the same thing will happen. Now, the notion is that you will wind up paying for expenses in some way that you caused. As a physician, you know that's almost impossible to tell. Like if you're significantly overweight and you have diabetes, there's some connection between those two things. Is it causal? Maybe, maybe not. So this whole notion of shifting responsibility to consumers, I think, is fraught with risk. And the kind of risk that you just identified is a significant part of it, which is that people that will really need care won't go get it, and then they'll wait, and in that way, and we know the longer people wait, the more expensive they are. It's not a great solution, is my point, but I mean, that is what's happening. You know, and I'm just trying to think of me as a reporter from the other side.
Well, Andrew, great presentation. Sandy, you set it up nicely for my question, which was, I'm thinking about that gap, the individuals who are uninsured. Let's just think about Texas.
Yeah.
They're employed, though, but
Yeah.
they're in low-paying jobs.
Right.
So they're going to decide to opt out, take the penalty in the ACA, because in their calculation, that's a better way to go, because it's too expensive to go
Right.
to the public exchange.
Right.
What are we going to do with that? I mean, how are hospitals going to be able to maintain
Well, so there are a couple of things.
profitability or even the ability to
Yeah.
be able to take care of these folks when they show up, because they are going to wait until it's a crisis. It's a critical
so
point
a couple
for
of
them.
things, you know, in the .gov exchange, you know, just the federal exchange, there is a subsidy. So depending on how poor you are, you get part of your health care premium picked up. But I agree. I think some people will decide the penalty is less expensive. And, you know, I am really supportive of what that law tried to do, which is insure everyone. I think the compromises, one of which you're pointing out right now, are horrible, right? And and it feels to me like legislation that has a lot of Swiss cheese in it, right? And that's one of them. Maybe I'll just pay the $100 a month and the heck with it, and then I'll just go to the ER and I won't pay that bill, and that'll be the solution. And I think there are a lot of things like that in the Act. The one thing that gives me hope is, if you look back at the history of Medicare, Medicare was a really horrible plan when it first passed. as legislation. And over time, people iterated and closed some of the gaps and made it a much more viable plan. And I'm hoping that's what happens. But I think the political maneuvering to get that legislation passed really twisted it in ways that, some of the incentives are really, really difficult to deal with. I think the other part of the legislation that was really horrible is, and I understand why it happened in the Supreme Court decision, but giving states the option, right? Because that option, it's just, in this state in particular, is just so ugly, right? It's just kind of, it really borders on just being flat out abusive of people that are economically disadvantaged, right? We're just not, you're not going to get to see a dentist, you're not going to see a mental health professional unless you wind up hopefully in David's organization getting care. But in general, we're going to punish you for being poor in terms of your health care outcomes and probably reduce your life because you're poor. And I think that is, it's just, it's just hard to believe that I love living in Austin, but it kind of ends there. Any other last questions?
Just as far as healthcare costs, do you see any changes with the pharmaceutical industry around? I know there's a lot of issues about research and cost of new meds and.
Well, I think the two places that need revision, if you look at hospital companies, they're making a lot of money. And if you know this, but I'll say it in here, if you know how pharmacy works globally, you know that the U.S. members of health plans are paying the freight for most of that. So you can go to Europe and get the same medication significantly cheaper than you can here. And that is because the way it's structured, it's not like that in Medicare, but it's like that in commercial, is that the companies that build those products and actually have those costs do not distribute them evenly pill by pill. It is depending on where you are in the globe. And since we're wealthy, we pay most of the expense. And I think that has to get reformed. It might not be a perfect reform. It might be that, there are parts of the world that can't. And the humanitarian thing to do is distribute medication there. But I don't think it can be as disproportionate as it is now. Because pharmacy benefits, and especially with some of the drugs that are coming out now, drive a tremendous amount of that 18% of GDP. And so, if you brought hospitals down to what hospitals make in Europe, if you brought pharmacy down, if you kind of understood that maybe some specialties like pain management didn't need to make $750,000 a year, and you start rationalizing across that level with hospitals, certain specialties, pharmacy, then you probably get to a closer thing of a rational healthcare system. Problem is, the problem is that healthcare in this country is political, right? It's not rational. And because it's so political, those different parts of the healthcare system have very, very strong lobbyists. We were talking about this whole issue about telehealth and why is it so restricted in this state? Well, we've tried to put telehealth programs up for years, and it's because the TMA wants to block people from practicing, living in Santa Fe, practicing in Texas, even if they're Texas licensed, using telehealth. And then the TMA is the second most powerful medical organization in the country, right? Yeah, they're nice people, but they guard the fences pretty tightly. Good. Okay. Thank you very much.